So I'm going to be talking about foodborne outbreaks. So I have a decent number of slides to cover, so I'll try to make this as quick and painless as possible. Okay, so let me start off by talking about the CDC's winnable battles. So I'm assuming some of you might have an idea about this. So winnable battles are mainly public health battles. These are public health problems which have a huge impact. And also, most of these, or all of these battles actually, are called winnable battles because we have strategies to overcome these problems. They not only cause a huge deal of loss of life, morbidity and mortality, but we have specific evidence-based strategies in place to overcome these problems. And that is why the CDC characterizes these as winnable battles. And as you can see on the top right of the slide, food safety is one of the winnable battles, and that hence I've included this slide. And I would like to take this opportunity to talk about, just say a couple of words about another winnable battle, tobacco. We have an expert in the room. Dr. Scott Frank has more than 25 years of experience working with tobacco cessation, so probably working with him. So this is how foodborne illness is defined. When two or more people get the same illness from the same contaminated food or drink, the event is called a foodborne outbreak. And this definition applies irrespective of whether the cases are in the same household. When cases are in the same household or have shared many meals or exposures, onset time should be closely evaluated to rule out person-to-person transmission. So that is how a foodborne outbreak is defined. The next two slides actually will focus on the burden of foodborne illness in the U.S. So this is very recent data. The CDC 2011 estimates, there's a recent study, and it estimates that each year about 1 in 6 Americans, or about 48 million people, get sick out of foodborne outbreaks. And about more than 100,000 people are hospitalized, and about 3,000 people die each year of foodborne outbreaks. So definitely this is a problem worth noting and worth tackling as well. So we have two major groups of foodborne pathogens. One category is the known foodborne pathogens. So there are 31 in number. You can go to the CDC's website and learn all about this. I have the references here. And there's another group of unspecified agents. So a bunch of diseases or foodborne outbreaks which are caused where you don't really know what the agent is. The special emphasis on multi-state or outbreaks that involve more than one state. 16 multi-state outbreaks occurred in 2011. Some of you might remember because of wide media attention. The outbreaks that occurred due to alfalfa, or that were traced due to the alfalfa sprouts. And the other famous one was peanut butter. In 2012, it's hardly been a month, and the first multi-state outbreak has involved a major restaurant chain. Any guesses? What is that? Burger King? Not really. It's Taco Bell. So yeah, so these occur pretty frequently, and it's something to keep in mind. And the role of the local health department, which we are all concerned with, and which this study is really all about, has a major role to play in multi-state outbreaks. And this may include prevention, investigation, or management. Does anybody in this audience know about the rule of HAPS? I'm sure the physicians in the audience will know about the rule of HAPS, but apart from the physicians, does anybody else know about the rule of HAPS? Okay, so this basically came about when people were studying hypertension. So the rule of HAPS is only about 50% in the community or in the public know that they have hypertension, and of those, about 50% of those actually go and get treated, and among the 50% who are treated, only about 50% of those actually are treated adequately. So it goes on like that. A similarity, it's very similar to what we have here. This is the burden of illness pyramid. So we have the population here. So not everyone in the population is exposed to, obviously, foodborne outbreaks, and everyone who's exposed doesn't become ill. Only a small number of people become ill. And among the people who become ill, not everyone seeks care. And among people who seek care, not every person's specimen is sent to the laboratory for being diagnosed or for the pathogen to be recognized. And then culture is confirmed. Not everything gets reported to the local health department, and not everything that gets reported to the local health department goes to the state health department, which is the Ohio Department of Health here. And the top level, which is the CDC, a very minute or very minuscule number of cases actually go to the CDC. In fact, a study which I actually haven't included here, but I came across, showed that there's wide variation in the states when it comes to reporting of foodborne outbreaks. I mean, this is real data. We need this data. We consider the information that's being put out by the CDC to be important information. So for the CDC to give out reliable information for us to make conclusions or to make changes as to how we investigate foodborne illness, we need to know the burden of illness or the burden of disease. If the numbers are not reaching CDC, they cannot tell us what's the real scenario. So it is essential that we have a good reporting system, and I'll talk about that a little more. A couple of slides about the economic burden of foodborne illness. So as you can see, per case it's more than $1,500, and the total aggregate per year is about 77 or close to $80 billion. That's a lot of money there due to foodborne outbreaks. Look at this graph. Pay some attention to this graph. These are the 4 or 5 major pathogens out of the 31 known pathogens that are known to cause foodborne outbreaks. So what do you see here? As you can see here, Campylobacter, which is the green line, sort of tapered off. It's actually kind of fallen down. Same thing with Listeria. From 2009, actually, there's a drastic drop here. However, look at Vibrio. There's a huge rise. There's a spike there. And Vibrio cholera is hardly seen in the US, yet there is a spike there. And I believe that this is because of travelers. Because the world is becoming a smaller place, we have a lot of travelers coming to the US from different countries. And cholera is something that's still prevalent in other countries, such as India, where I come from. So a lot of them actually are due to travelers bringing in the disease from different places and spreading it to people here. So that's why this is something that's any other things that you might think of, Dr. Frank? That was my number one suspicion, actually.
I think that's probably the major influence, but I can say that the other part is that U.S. physicians simply aren't very aware of cholera. Because it's not been in the U.S. For such a long time, it may be underdiagnosed in the physician's office, which means that it could be more easily transmitted outside the physician's offices. And as you'll make a point soon, I'm sure, carrier states for Vibrio are important mechanisms of transmission. So if we're not aware, not making the diagnosis, not finding it in carriers, not testing other family members, when an index case presents, that kind of thing would make it spread more easily.
Thank you. And of course, this is something that we want you observers to capture when you're doing your direct observations. So there's definitely a seasonal variation in foodborne illness. So as you can see here, there's a spike between these months from May to September, and then there's a drop again during the winter months. Again, it goes up. So there's definitely a spike in the spring and summer months where people tend to eat out more, for example. So we want to capture the seasonal variation. We know that there's a seasonal variation, though this data is actually from 1996, or more than a decade ago. But this is seen pretty much every year. So we were hoping that through the study we can capture the seasonal variation in foodborne illness. And of course, in public health, one thing we talk about very often is about vulnerable populations. So in this group, in this graph rather, we see the variation in foodborne illness by age group, and the younger age groups are actually more affected by foodborne illness. even though, as you can see from the first bar, the age group that's less than 1 and from 1 to 9 people in this age group they are hard to eat out, but then again, they are more susceptible to these deadly infections because of transmission within the household from other people who might be eating outside and who might get the infection from elsewhere.
They also may simply be more likely to be diagnosed, however, because the illness is likely to have greater consequences in infants. So an adult may not seek diagnosis when having it, but parents going to bring their child in with the same symptoms, that they'll just wait to see what they pass for themselves.
So it was Ben Franklin who said an ounce of prevention is worth a pound of cure. So that's what we all do. We aim to prevent rather than wait for the illness to settle and then look for a cure. So coming to identifying the risk factors for foodborne outbreaks. So there's a bunch of risk factors. There's cross-contamination. There's food that's from unsafe sources. Because of the industrialized nature of the US and many other countries for that matter, food is sourced from different places. It can come from Mexico, it can come from several other places, it can come from different states, some of it is locally grown, so it's sometimes very difficult to trace the source of the outbreaks. And it becomes pretty difficult, but that's one of the reasons why foodborne outbreaks happen. Even though we are pretty stringent about how we handle food that's imported from different countries, it can still happen. Inadequate cooking, inadequate holding temperatures, contaminated equipment, poor personal hygiene, food handlers' health status, water quality, presence of pests, and a bunch of others. Sure, all of you know about Typhoid Mary. She was an Irish immigrant who came to the US, settled in New York. She was a food handler, most important thing, and she resulted in causing typhoid in more than 50 people, or spreading typhoid to more than 50 people, and resulted in almost about 3 deaths. So until she was actually apprehended by the authorities and put in quarantine. And the importance of Typhoid Mary, and the reason why I included this slide as well, was because she was an asymptomatic or a healthy carrier, and there could be a lot of healthy carriers among people who might be preparing food in those restaurants. We never know, and which is why it is so important or essential for them to take all these safety precautions like wearing gloves, wearing face masks, and wearing headscarves and things like that. So there could be many Typhoid Marys. Let's hope not, but it's quite possible.
Let me just tell a quick story. After she was actually jailed because she refused to not work as a food service operator, and finally was released because she promised not to. She changed her name and left New York City, went to Buffalo, and about 3 months after she arrived in Buffalo, there was a typhoid outbreak in Buffalo that was actually quite large. So wherever she went, typhoid followed her.
That's right. Even though she actually said that she would work as a cook or a food handler, she did in fact work. And Dr. Frank mentioned she ended up spreading typhoid even in Buffalo, and I think caused 1 death there. So, and she was again apprehended by the authorities, and after that she wasn't released, so she died in quarantine. So why food service establishments? Why are you going to be shadowing sanitarians? Why is this important? So look at this graph. It's again from the Center for Science in Public Health Interest. And 44% of the foodborne outbreaks occur in restaurants. So it's the bulk of foodborne outbreaks. And after that we have others like private homes and locations and things like that. So but nearly close to 50% occur in restaurants or food service establishments, which is why we're so concerned about this part.
But you may find yourself involved in investigations in pretty much everything except the private home. Actually, with cases, we may even be involved with private homes, but health department personnel do preventive inspections of catered events, and one of the notorious places would be the county fairs, that kind of thing, and we inspect those. So it won't just be traditional restaurants that you're in. You'll go wherever the sanitarian goes. That also may include schools. So from catered events to workplaces to religious or social clubs, schools, you may be involved in many of those sites as well as the food service establishments.
So what is the role of the local health department? The local health department has multiple roles, and chief among them are to ensure safe and hygienic procedures, conduct routine inspections, establishing and enforcing established standards, and this is something which I'll talk about later, but this is a consortium that Council to Improve Foodborne Outbreak Response, or CIFOR. It was a 3-year-long process. A bunch of different agencies came together. They wanted to create standardized guidelines in order to standardize how a foodborne outbreak is investigated and managed. So you can go to CIFOR, you can just Google CIFOR, and you can go and look at their comprehensive document, and we can include that, we can send you all guys a link, and we'll probably include that on our website because it's really useful, and I'll talk about it a little later. And of course they also influence local, state, and national policy on foodborne outbreaks and foodborne illness, and of course they also impart education on personal safety precautions to prevent foodborne illness. A couple of minutes on essential public health services. So there are 10 essential public health services, and any public health service for that matter, and it's not just foodborne outbreaks, it's any public health service should encompass these 10 essential public health. So it's providing care, assuring a competent workforce, evaluating, monitoring health, diagnosing and investigating, inform, educate, empower, mobilize community partnership, develop policies, enforce laws, and at the heart or core of it all is research, which is what we are engaged in, and which is so important to bring out evidence-based, or bring out solid evidence to enforce all of these other things, or bring out guidelines or policies and things like that. How does this fit in with the work that we're going to be doing, or with foodborne outbreaks? A lot of things actually, or most of these, as I said, enforcing laws. Local health departments enforce laws. They have stringent guidelines for when new restaurants need to be open. They educate, they inform and empower the public. You can contact the local health department or the state health department whenever you suspect that there is a foodborne outbreak. They have a competent workforce. They are silent warriors. They are registered sanitarians and environmental health specialists. They go out and they do their job and keep food safe for us to eat. They monitor health, and they also diagnose and investigate. We have a trained set of epidemiologists at each health department, and microbiologists and several other personnel who do the job. So who are the key personnel involved in the prevention side of things? So we have the most important person here is the food inspector, whom you will all be shadowing, or the environmental health specialist. In some health departments, especially the smaller health departments, there's not a specific person for doing the food inspections. There's a guy who does multiple things. He has multiple roles. He not only does food inspections, but he also does sanitary inspections. He goes and sees septic tanks, for example. He does a lot of other things. So he has multiple roles. And at a bigger health department like Cuyahoga County Board of Health, we have a bunch of trained food service specialists who do nothing but food service establishment inspections. And of course, we have the administrator who usually orients people and people, as well as other key people involved when there's a foodborne outbreak. There's an epidemiologist who also plays a vital role, microbiologist, and there's a public information officer who disseminates information regarding the foodborne outbreak. So what are the health communication efforts? Sorry, the top of the slides, I mean, you get cut off for some strange reason, but you will see them on your paper handouts. So what are some of the health communication efforts to decrease foodborne outbreaks? The most important thing, as you might have all read come across in your classes, public health classes, hand washing. It's so important. We have LHDs, the local health departments actually grade restaurants. This is sort of, I would say, a new thing. A lot of health departments or a lot of other states are picking this up. New York City, for example, this is from the New York City Department of Health and Mental Hygiene. So they grade restaurants. They give grade A, grade B, and grade C. And depending on the number of violations or sanitary violations, the Cuyahoga County Board of Health gives an award called the Be Food Safe Award. You can look it up on their website. And this is, I mean, they have to, I think, have about 3 or 4, they have to adhere to 3 or 4 different things to get this award. I mean, the restaurants get this Be Food Safe Award or something like that. I think one of the things is they have to comply with Ohio's revised food code, one of the things. The second one is that they should have 0 violations. It's pretty tough. But, look out for these restaurants. You can dine in them. And of course, posters, educational material, things like that to disseminate information to the general public as to how they can avoid foodborne outbreaks. So the investigation part of foodborne outbreaks. So we are part of reporting foodborne outbreaks to local health departments or state health departments. And as soon as they get a call from us, they go and investigate. It's investigate as a complaint. I had the opportunity, along with Michelle, to shadow a couple of sanitarians, see the work they're doing, and a couple of them actually during the day were complaints. So 2 restaurants, the food served at these restaurants had some problem. I won't go into those right now. As soon as they got a call, within a couple of days, the sanitarians went to these restaurants to investigate what was happening. And if everything was being done, food was being prepared properly at these restaurants, food was being stored properly at these restaurants. So a detailed investigation is done whenever they receive a complaint. So, and we are responsible for actually informing the local health departments about these problems. Medical evaluations from healthcare professionals at hospitals, clinics, or physician offices. So when people go with diarrheal disease or with any gastrointestinal symptoms, and the physician asks you for a history, did you eat outside, something like that. So that's one possible way when how the source of the contaminant can be traced. This is most important: routine surveillance and case investigation of reportable diarrheal diseases by epidemiologists and public health nurses at state and local health departments. It's very important. Routine lab testing and techniques conducted by microbiologists, another way of detecting foodborne outbreaks. Information received to the media and public information officers. Reports from state and federal food safety regulators and environmental health specialists. So these are some of the things that are involved in the investigation part of foodborne outbreaks.
Okay, the next step here is how does one proceed with the investigation? So there's basically 5 steps in proceeding with the investigation. The first step is conducting a hazard analysis. So this is where people go to sites, the sanitarians go to sites where the foods responsible for the outbreaks are produced, processed, or prepared. They trace the sources of contamination, they identify the factors responsible for contamination, and they interpret the collected data, and finally they report information about the outbreak. So here's just a flow diagram or a flow chart that shows how the data flows from the consumer to the CDC. So as you can see, the consumer becomes ill, he seeks medical care, samples are collected, it goes to the lab, then there's a formal epidemiological investigation, the outbreak gets reported to the CDC, and the CDC compiles all of these outbreaks that they get from the states and other local health departments. And again, this is a busy slide, but here's a more detailed overview of how data gets to the CDC from the point source of the outbreak. And I'm going to skip over some of this because it's a really busy slide. I have it broken down elsewhere. And coming to the CDC, here we have a bunch of things that the CDC does. It has an excellent network of sentinel and surveillance systems, and as you saw in the previous slide, it's about 6 or 7 of them, and if you can go to the CDC's website, and if you look up FoodNet, it's an excellent surveillance system that they have that's in place for people to report foodborne outbreaks. So as I was saying, the CDC has an excellent sentinel surveillance network system, and I'm going to quickly go over some of these. So there's the foodborne disease outbreak surveillance. The CDC collects data from local and state health agencies through the National Outbreak Reporting System, or the NARS. And then there is the FoodNet, the Foodborne Disease Active Surveillance Network. It is the principal foodborne disease component of the CDC's Emerging Infectious Program, and it's a sentinel surveillance system. Unfortunately, not all states have signed up for this FoodNet, and Ohio is actually not one of the states. And then there is the National Antimicrobial Resistance Monitoring Program. There's the National Electronic Norovirus Outbreak Network, or the CalCNet. This is for calcivirus. And there's the National Molecular Subtyping Network for Foodborne Disease Surveillance, or the PulseNet. This is a national network of local, state, territorial, agricultural, and federal laboratories. So it's established in all 50 states and 82 countries. It's coordinated by the CDC and the Association of Public Health Laboratories. The CIFOR, or the Council to Improve Foodborne Outbreak Response, put out a set of guidelines, and these guidelines were the result of a 3-year process that brought together public health and food safety practitioners and experts from all levels of government to improve the response to foodborne outbreaks and create a common framework for evaluating foodborne disease surveillance. So local and state health departments have started deploying these guidelines. Unfortunately, a recent study showed that the deployment of these guidelines is not as would like it to be. Among the states, about 47 of the states said they plan to read the document. 39 states said they plan to distribute it. 29 plan to review their practices against the recommendations in the guidelines. But only about 27% said that they would like to put this into force. Let's talk about surveillance. Disease surveillance is used to identify clusters of potential foodborne illness, and there are 3 main types of surveillance. There's pathogen-specific surveillance, there's notification and complaint systems, and then there's syndromic surveillance. Pathogen-specific surveillance is usually by healthcare providers or laboratories. When they come to know about a certain pathogen, it gets reported. Notification or complaint system also pretty much works in a similar way. You go to a physician, and there are certain notifiable diseases. There are complaint systems in place, and these notifiable diseases get reported to the central authorities or the regulatory authorities. Syndromic surveillance is slightly different. This is where when people go to emergency departments, or for example, let's say when poison control centers get calls on certain disease outbreaks, it gets automatically reported to central authorities or regulatory agencies which are responsible for handling these outbreaks, and that is syndromic surveillance. So let's talk about the role of the LHD. As you can see on the slide, the LHD has a variety of roles. It has a role in prevention, surveillance, identifying in local and statewide outbreaks, foodborne outbreaks, coordinate multi-jurisdictional outbreaks, provide advanced laboratory testing, support or direct environmental, laboratory and epidemiological investigations with advanced expertise, provide health education and promotion materials, maintain tools for collecting and analyzing outbreak-associated information, provide public information, provide legal support for outbreak investigation and control, promote statewide policies to increase food safety, serve as a liaison and coordinate communication and disseminate information as well. So why LHDs? We are all interested in LHDs, and we are going to be working closely with a lot of local health departments. So why LHDs? So LHDs are so important because they're routinely involved in preventive inspections. They are often the first, or pretty much all the time, the first responders to foodborne outbreaks. There's a high degree of variation, which you will definitely see in the coming months in preventing and investigative procedures. And of course, there's limitations related to budget and staffing in most local health departments. So they usually environmental specialists and sanitarians often have competing priorities, and they are not in many local health departments. They have multiple roles. In bigger health departments, usually sanitarians, there we have specialist sanitarians who do nothing but sanitary inspections, but in many small health departments we have them doing lots of other things, such as septic tank investigations or inspections and things like that. So definitely they have competing priorities which come in the way of routine investigations. So moving on to what are the barriers that that LHDs face. So there's moderate or substantial barriers reported by states, and this is from a study that's on the CDC's website. So there's delayed notification of the outbreak. This is reported by 41 states. Lack of sufficient number of foodborne safety staff members, 29 states. Lower prioritization of investigations, 27 states. Lack of ability to pay overtime, 20 states. Lack of adequate epidemiology expertise, 12 states. Difficulties working with in-state agencies, 8 states. Constraints related to administrative support, 8 states. And difficulties working with other state or federal agencies, 5 states. So these are some of the barriers that LHDs have reported to the CDC. So the following video will show you what a typical restaurant inspection is going to look like and what you guys will have to be looking for when you actually go out on these inspections. You will see a more detailed inspection video later on that we have shot, but this is something that you can also use, and it'll be helpful for you as you move along or move forward in this project. So these are some of the steps in the inspection of a food processing facility. So the first step is the pre-inspection or the preparation for the inspection. And then there's the inspection opening meeting with the person in charge or the food service operator. And then we move on to the counterflow, or we walk through the steps of the inspection. Usually sanitarians have a detailed checklist that they go through. There's a flow chart. They go through each and every single item. Experienced sanitarians have these flow charts at the back of their mind, so they make sure that they go through each and every single one of these checklists, and mostly they deal with physical inspection items such as looking how clean the floor is and things like that, how dishwashing liquid, temperature, and things like that. Moving on, let's talk a little bit about prevention. And this is actually your last slide. So the prevention component will allow you observers to accompany inspectors as they perform their normal inspection or educational duties. The observational teams will rely on each health department to help them understand the particular processes they employ to encourage and assure compliance with food safety regulations, and for providing on-the-spot and follow-up education regarding food safety. So what you guys will be doing will be looking to learn the standard methodology to inspect the various facilities and how inspectors interact with food service operators or other employees in the restaurant or a food service establishment, and you'll be helping them in compliance and understanding the purpose and value of food safety. So that's the major goal here. That's the end goal here. You'll be observers. You're not shadowing a physician. It's not like shadowing a sanitarian, and you'll not be interacting. You are a research observer. Please keep that in mind, and good luck moving forward with this project.